Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. Today's episode, Dr. Chloe Orkin from Queen Mary University of London in London, UK, and Dr. Jean-Michel Molina from the University of Paris City in Paris, France, discuss highlights from CROI 2025. For more information about this program, including downloadable slides and expert-authored commentaries, please visit the link in the show notes for this episode. Now let's get started and hear what our experts have to say about this important topic, starting with Dr. Orkin.
So I'm going to start with treatment. And what we heard at this conference was an updated analysis from the CARES study, which evaluated long-acting cabotegravir in sub-Saharan Africa. And it used a public health approach. And what that means is that the clinicians who enrolled people did not have access to the baseline genotypic test. They didn't know the resistance test at baseline. And people were dosed with 2 monthly cabotegravir versus oral therapy. And we've already heard the 48-week results, which showed that cabotegravir was non-inferior to oral ART. So this analysis is looking at week 96. And as one more reminder is that in the study, people were monitored 6 monthly. So the frequency of viral load monitoring was very infrequent compared to what we are used to. So importantly, the study enrolled 58% women. 1 in 5 had a BMI greater than 30, predominantly Black participants with a median time on first line of 8 years. Importantly, 74% had prior exposure to NNRTIs, but most people, not more than 90%, were on integrase inhibitors at the time of switch. So the baseline characteristics were balanced. And as I've said, they were enrolled without resistance testing. However, there was retrospective proviral DNA testing. Okay, so archived proviral DNA testing at baseline. So we could see what resistance people actually had. 55% of people had the A1 subtype. And this is very important because in the past, we thought that this subtype was associated with virological failure. And we can see very clearly that this is not the case. But what we do see is that there were small proportions of people who had rilpivirine resistance at baseline, even high-level resistance, and also cabotegravir high-level resistance. So what is important to say is that at week 48, it looked as though there were 10% with rilpivirine intermediate or high-level resistance and 8% with cabotegravir intermediate or high-level resistance. However, what they did is for the week 96 analysis, they excluded APOBEC-related mutations. So why is this important? It's because APOBEC is related to the host response to viruses, and these mutations have very little effect. They can reduce the ability to replicate, so they can make the virus less competent and less replicatively fit. So it gives false confidence for us to think that we had 10% with high-level rilpivirine and high-level cabotegravir, when actually some of these mutations reduce the viral fitness and the replication capacity. So by excluding APOBEC-related mutations, we reduce this and we give a more accurate representation that only a very small proportion of people had these mutations. So what we can see in terms of the outcomes is excellent outcomes, almost identical to last time. We can see that in cabotegravir, nearly 97% undetectable. And what you can see is also that 97% of injections were administered on time. There were very good outcomes, very low levels of serious adverse events. And we saw that ISRs were very similar to usual, which is that they rarely lead to discontinuation. And treatment satisfaction was greater, just like at week 48. And more than 99% preferred long-acting treatment in the study. So in terms of virological failures, there were 2 people who experienced virological failure up to week 48. At week 96, there were 4 participants. And this leads to a percentage of 1.6%. Participant 1 had 2 viral loads in excess of 1,000. Participant 2 had a very high viral load. Participant 3, some lower level viral loads, less than 1,000. And participant 4 went up to 16,000. In 3 cases, there were both NNRTI and cabotegravir mutations. Importantly, the participants were all in the lower BMI category, and the mutations were at baseline, there was 1 person with a cabotegravir resistance mutation and 2 people with minor NNRTI mutations. So those were the resistance findings. There was 2 studies presented on switching people who are virally suppressed to doravirine islatravir from oral treatment. The first study switched people from bictegravir, FTC, and TAF, and that was a blinded study. And the second study was an open label study switching people from any oral treatment to doravirine islatravir. And this was the lower dose of islatravir that has been dosed subsequent to the CD4 signal in the past. So this was the lower dose of islatravir. And what you can see is that there was non-inferiority for doravirine islatravir in both studies. Okay. And the other thing that's important is that there was no treatment emergent resistance to doravirine or islatravir in either study. So what about the CD4 count and lymphocyte signal? In the blinded study, we see total lymphocyte count and CD4 counts tracking together. There was no difference in mean percentage change from baseline. The open label study showing similar findings. There was no adverse effect on lymphocyte count in terms of the study at the lower dose of islatravir. So what did happen in terms of safety is that although there were no clinically significant HBV reactivations, there were 3 cases of low-level viremia without antigenemia or elevated transaminase. Now, remember, in the study, people had tenofovir or TAF FTC withdrawn, and therefore they had a Hep B suppressive regimens withdrawn. 2 people developed acute hepatitis B. So essentially, we can say that in terms of changes of total lymphocytes, these were consistent, and in terms of discontinuation rates, the same number of people discontinued due to CD4 count in the blinded study, and nobody discontinued due to CD4 count in the open label study. In terms of the changes in terms of weight, in the blinded study, the results were very similar in the significant differences. But in the open label study, what happened is that overall there was a difference. Okay, there was more weight gain on doravirine islatravir, but this was related to the fact that a reasonable proportion of people had been on TDF or efavirenz. So when we took away the weight suppressive drugs, then we saw weight gain in these participants, but not in the participants without that. So that's the summary of the treatment studies.
And I'm going to talk first on neutralizing antibodies. And you know that there is a high interest in using these neutralizing antibodies. And the first study I'd like to highlight is the study shown here, where people received a triple combination of lenacapavir, teropavimab, and zinlirimab. So teropavimab is also called TAP, and it's a neutralizing antibody which targeting the CD4 binding site of GB120. It was formerly called 3BNC117LS, and the second neutralizing antibody, zinlirimab, is targeting the 3' loop of GB120 and was formerly known as 1074LS. And so the goal of the study was to show whether this triple combination would be able to maintain viral suppression in people living with HIV, adults, being fully suppressed on oral ERT drugs for at least 12 months, with at baseline viral susceptibility to the 2 neutralizing antibodies using a Phenosens assay, and with the CD4 cell count above 200. And these people had to be HPV negative, since neither lenacapavir nor the neutralizing antibodies have activity against HPV. And the primary endpoint of the study was to look at the proportion of people with an HIV RNA plasma level above 50 copies per ml per the FDA snapshot analysis at week 26. And surrogate outcome included CD4 cell count, changes, PK of the neutralizing antibodies, and the detection of anti-drug antibodies at week 26. When you look at the first row, the people who had a viral load above 50 copies per ml, only a single individual in the lenacapavir had virologic failure, which was detectable at week 12. And in this individual, it happened that the len concentration were actually lower than 1 standard deviation below the mean. And at week 24, in this individual, there was resistance to lenacapavir detected with a mutation at position 67. And there was also a loss in ZAP susceptibility. This patient was put on bictegravir, FTC, and TAF, and was doing well. Overall, a very high proportion of participants, 96% in both arms, remain undetectable, and that a low proportion of participants in the len-tab-zab anti-drug antibodies detected, and indeed the participant who had virologic failure didn't have anti-drug antibodies detected. The second study using neutralizing antibodies was the EMBRACE study, where another antibody, N6LS, was used. This antibody is also targeting the CD4 binding site of GB120 and was used in combination with cabotegravir in people already suppressed under oral ERT. So in this randomized study, Again, adults with a viral load below 50 copies for at least 12 months, with no history of treatment failure, with a CD4 cell count above 350, no HPV infection, and with type X sensitivity to the antibody at baseline, were randomized to either the combination of N6LS IV every 4 months plus cabotegravir every month. And that's different from the current use of cabotegravir, which is usually given monthly. The second arm received N6LS 3,000 milligram plus carbamide hyaluronidase because the injection was given subcutaneously, whereas the first received N6LS IV. Again, this injection was given every 4 months, plus cabotegravir every month. So again, a different schedule from what is currently being used. And the third, continue the oral standard of care ERT. Again, the primary endpoint was the proportion of patients with an HIV RNA level above 50 copies at month 6. And in terms of key secondary endpoints, we're going to look at the rate of viral failure with a viral load above 200 copies per ml, safety, and CD4 cell response. 4% of people with an HIV RNA above 50 copies in the IV N6LS, 6% with the subcutaneous N6LS, and none in the oral standard of care. This corresponds to actually 5 participants with a load above 50 copies per ml, and above these 5, only 4 had confirmed virologic failure, so a viral load above 200 copies per ml. And in these 4, 2 were in each N6LS. In the first arm, those were receiving IV N6LS. None of them developed InSTI resistance, but both had an increase in the IC90 to N6LS. In the 2 with virologic failure with subcutaneous N6LS, 1 developed InSTI resistance, but none had increase in IC90 to N6LS. All suppressed when switched to standard of care oral ERT. There was no adverse event leading to withdrawal and no serious adverse events related to CAB or the antibody. There were injection site reaction, less frequently seen with IV as compared to subcutaneous injection. And according to these results, because when you look at the proportion of people who remains virologic suppressed through 6 months, you can see that there was a pretty high proportion of people, nearly 90% or 96%, who remain virologic suppressed. These results were considered good enough to continue the investigation of this combination with the IV N6LS administration every 6 months, plus long-acting cabotegravir. We also looked at interesting data from 2 phase 2A studies looking at new drugs. The first one was VH184. That's the 3rd generation InSTI, which demonstrated in vitro activity against dolutegravir resistance mutation. And this drug was given orally to people living with HIV as monotherapy. And with monotherapy with VH184, you could reach at day 10 a decline by at least 2 logs of the HIV RNA, which was quite remarkable, with a dose ranging from 50 to 300 milligrams. There was no serious adverse event, only grade 1 and 2 adverse event, and this drug is going to be investigated as a long-acting injectable for HIV treatment. The second new drug was VH499. This is an HIV capsid inhibitor, and similar to the previous drug, it was assessed in people living with HIV as monotherapy, and given orally, this drug achieved a decline in viral load ranging from 1.8 to 2.2 after 10 days. However, 1 participant who received a low dose of VH499 developed emerging capsid inhibitor resistance. So this is to keep in mind. So this drug has most likely a low genetic barrier to resistance. Nevertheless, the safety was good, no serious adverse events, only grade 1 and 2 adverse events. And again, this drug is planned to be investigated as a long-acting injectable agent for treatment. Let's switch now to the Rio trial. This was one of the highlights of the conference. And here, the ambition was not only to keep people well suppressed, but the idea was to see whether a combination of BNAbs would be able to confer viral control when people are off ERT, and if so, for how long. So this was a study conducted in the UK and Denmark, a placebo-controlled, double-blind, randomized study, using the 2 neutralizing antibodies that we discussed before, TAB and ZAB. And these antibodies were given in adults who have started ART at the time of primary HIV infection or with an AD of CD4 above 500, who have been virologic suppressed for at least a year on ART prior to enrollment, and who had no resistance to 1074 neutralizing antibody at baseline. And these participants, 34 per arm, received the antibody or placebo, and then underwent an ATI, analytic treatment interruption, for up to 20 weeks. And during that period, ART was stopped, and HIV RNA was monitored every week for the first 8 weeks, and then every 2 weeks. And the primary endpoint here was to look at viral bound by week 20 after ART interruption. And viral bound was defined as an HIV RNA above 1,000 copies per ml 6 times, or an HIV RNA above 100,000 copies twice. In the study, they looked at key secondary endpoints in terms of safety and long-term viral suppression. In terms of the primary endpoint, by week 20, you could see that 75% of those who received the BNAbs had no virologic rebound by week 20, as compared to only 8.8 in those receiving placebo. And this is highly significant, and this is a remarkable result. But what's even more interesting is to look at what happened after week 20. And after week 20, those participants who remain undetectable were allowed to receive a second injection of the BNAbs or a placebo. And what we can see here is in those receiving the BNAbs, the median time to rebound was 62.3 weeks. So that's very long. And among those who received the BNAbs and who had not rebounded by week 20, 57% had no viral rebound by week 48. And what is, I think, even more striking is that 7 out of 29 participants receiving the BNAbs remained virologically suppressed for more than 72 weeks off ART. And this is interesting to investigate further. There was no discontinuation of the BNAbs or ART because of serious adverse events, no infusion reaction. There was one death, but it was not related to the treatment. And also, participants who started ART achieved viral resuppression by week 12, or at least 94% of them. So what are the key takeaway messages regarding treatment? Well, CROI Orkin told you that in CARES, using a public health approach in Africa, a switch to CAB repeater in LA was non-inferior to continued standard of care oral ART through week 96. Also in phase 3 studies, the switch to oral doravirine islatravir using a low dose of islatravir was non-inferior to continuing baseline peak FTC TAP or other standard of care oral ART regimen through week 48, with no differences in total lymphocyte or CD4 T cell count changes. Also, 96% of participants maintained viral suppression with the 2 investigational BNAbs and another investigational BNAbs in combination with long-acting ART in phase 2, phase 2B studies. And we are awaiting a long-term safety and efficacy data. The 2 new drugs, VH184 and VH499, demonstrated potent antiviral activity. One is the 3rd generation INSTI, the other one an investigational capsid inhibitor. And both drugs are planned to be tested as long-acting injectable for HIV treatment. And in the Rio trial, 75% of participants who received the 2 neutralizing antibodies had not experienced viral rebound by week 20. And among these participants, 24% remained virologically suppressed off ART by week 72. Let's switch now to HIV prevention. The first study was an CTG study, the PILAR trial, which was conducted in high HIV epidemic priority areas in the US using long-acting cabotegravir for PrEP. This was a phase 4 trial assessing integration of long-acting cabotegravir in 17 clinics. Interestingly, 22% of participants had not received prior oral PrEP, at least in the 6 months prior being enrolled in the study. And this study enrolled 201 participants. Interestingly, 6% were transgender men, 38% Hispanic or Latinos, and 26% Black. So there was pretty large diversity in terms of enrollees in these trials. What was interesting is to see that at month 12, 72% of the participants completed all injections. And when we look at candidate persistent during the study, we got here a very high rate of persistence, 85% at month 6, 73% at month 12. None of the participants acquired HIV infection through month 12 of the study, and very few had acquired STIs. Let's switch now to the HPTN 083 study. You know that this trial actually demonstrated the efficacy of Cabernet among MSM and transgender women as compared to TDF FTC. And in that sub-study, Rafi Landowitz presented data among people who experienced breakthrough HIV infection during Cabernet. There were 47 participants who had breakthrough HIV infection. They were, very rare infection according to more than 2,000 people enrolled in the study. But that was interesting to see what happened to these people when they received treatment for HIV infection. You could see that these breakthrough infections were ranked whether or not people received a Cabernet injection in the prior 6 months. And you could see the time at which breakthrough infections were notified and whether or not people received INSTI-based ART or other ART regimen. The majority of people were suppressed during follow-up. And if we look now at people who had actually INSTI-RAMs detected at the time of breakthrough HIV infection, you could see first that 8 out of 9 people who had INSTI-RAMs detected were people who had received a Cabernet injection in the prior 6 months. So that is quite reassuring regarding the long tail of Cabernet, explaining that or supporting the fact that there is probably little chances of developing INSTI-RAMs during the long tail. It's really those who have been on Cabernet in the prior 6 months who are at high risk of INSTI-RAMs. The other message from this study was also that all participants who had INSTI-RAMs detected, you can see that most of them received a non-INSTI-based regimen, but even the participants who received an INSTI-based ART all suppressed viral replication during follow-up. Indeed, this is a limited set of data, and we probably need more data to guide the choice of optimal ART regimen for people acquiring HIV during PrEP with Cabernet.
So I'm going to talk a little bit about potential future prevention therapies. So this is the Purpose 1 study, and I'm sure this is familiar to every single person in our field. And this, just to remind you all, this is lenacapavir in cisgender women, and that was the main study. And people were randomized to receive lenacapavir, which they started with an oral lead-in, and then they received 6-monthly injections. And the comparators were either FTC and TAF or FTC and TDF. And the outcomes, the primary endpoint, was looking at HIV incidence versus the background incidence in the population. So that was the primary endpoint. But this particular study was looking at what happened in adolescents, because this is the first study to have actually managed to enroll adolescents and allowed emancipated adolescents to consent for themselves. And they did this by approaching regulators and working with their community advisory board. And it's really a landmark study in this respect, that they were able to enroll adolescent participants without their parental consent. So what we're looking at here is the outcome in these adolescents. So we're looking at the number of people who are 16 to 17 years old. So in all participants, the background incidence was 2.41 per 100 person years. And in the lenacapavir, there was 0 incident infections. In the FTC, it was 2 per 100 person years. And in the FTC TDF, it was 1.69 per 100 person years. But now we're just looking in this study at adolescents aged 16 to 17. This is a very small number of people, only 56 people in the lenacapavir arm versus 45 in FTC TAF and 23 in FTC TDF. But there were no infections in any of the adolescents. So ISRs, injection site reactions, were the most common adverse event. And here's the important finding, that among adolescents, there were no lenacapavir discontinuations due to adverse events. So no discontinuations on lenacapavir. And grade 3 lab abnormalities were slightly more frequent in adolescents. But what's really important is that the trough concentrations of lenacapavir were similar between adolescents and adults. So no more discontinuations, and the trough concentrations were similar. So now we're going to look at the pipeline. So the pipeline for long-acting PrEP is actually really exciting. We have a once-yearly intramuscular lenacapavir being developed. And this is a 5,000 milligram dose, 5 mils of 500 milligrams each. And what was found is this is an intramuscular injection, okay? So it's 2 doses and it's intramuscular injection. So unlike subcutaneous len, which we've just seen, 6 monthly, this is intramuscular and it involves 2 doses. So what we're seeing here is that the concentrations of len once yearly IM versus twice yearly subcutaneous len were actually higher for the once yearly IM injection, and it was safe and well tolerated. The most common adverse events were ISRs, but they improved with pre-treatment with ice, and there were no nodules observed. So the plan is to investigate this as a long-acting PrEP option, so yearly intramuscular len injections. The other exciting thing was MK8527 NRTTI. So this is based on a population macaque PK model, looking at the 6 milligram once monthly dose expected to maintain PK threshold in more than 90% of people. So the potential here is to investigate this as a monthly oral PrEP option. So we're thinking that we might end up with potentially maybe yearly PrEP and potentially once monthly oral PrEP. So that is the very exciting options. And then what we're going to see now is unfortunately much less exciting. And this is the results of the STOMP study. And what they looked at is tecovirimat in persons with confirmed or presumed Mpox. So this study is the US study, and it follows on from the PALM 007 study, which also reported in the Democratic Republic of Congo. And in the PALM 007 study, there was no benefit to tecovirimat, okay, so none at all. So this US study is now looking to see if they could find a benefit for tecovirimat. So this was a randomized double-blind placebo-controlled study comparing weight-based tecovirimat versus placebo for 14 days. And the study was randomized, but there was also an open label option for children or pregnant people or people with severe immunosuppression or severe skin disease. So they took those out of the randomized group and they put those in an open label option. And the endpoints were time to clinical resolution by day 29. The secondary endpoint was pain scores, MPXV detection, and patient-reported outcomes. The median age was 34 years, 99% were male, 53% were white, and 44% were Hispanic. And what you can see in terms of the baseline characteristics, the median days from symptom onset were similar. They were similar regarding severe pain. They were similar regarding median number of lesions, and also similar regarding percentage of proctitis, HIV diagnosis, and prior smallpox vaccination. So here we see no difference in terms of clinical resolution, symptom duration, number of lesions, and however you analyze the data by HIV status or smallpox vaccination, nothing modified the treatment effect. And what was shown is that while it was safe, tecovirimat did not improve time to skin lesion resolution or pain control, and therefore the STOMP study was ended early due to a futility analysis, and therefore the results concur with the results of the PALM 007 study, which predominantly enrolled clade 1 participants. These participants were predominantly clade 2B. So that's unfortunate. So in terms of key takeaways, in terms of HIV and STI prevention, what we saw is that in the PILLAR study, there was high long-acting cabotegravir persistence through month 12 in high epidemic priority areas. When we were looking at how to treat people who acquired HIV on long-acting cabotegravir in the HPTN 083 studies, what we saw was that all participants with integrase inhibitor RAMs achieved virological suppression. In the Purpose 1, there were no seroconversions amongst adolescent girls aged 16 to 17 who received lenacapavir as PrEP, and the PK and safety data were comparable to women. When we look at the STOMP study, tecovirimat for Mpox did not improve time to skin lesion resolution or pain control. And now we're going to move to the Q&A, and there are some questions. So the first question is around the CARES study and asking whether there's any role of proviral DNA testing in determining the right person for cabotegravir or pivirine treatment. And I think what I would say is that overwhelmingly in this study, these participants were recruited without resistance testing, and yet we see 97% non-inferiority. Okay, we see 97% achieving viral loads undetectable without a genotype. And this is in a population who were heavily NNRTI experienced, where 74% had previously received NNRTI regimens. So I think if there was ever a time to say we don't need DNA testing this study shows that, in my opinion. I think we need to look at the treatment history, as these investigators did, and you can see the excellent results that they got when reviewing the treatment history. I don't know whether Jean-Michel disagrees, but that would be my answer.
Well, thank you, Chloe. I think this is an interesting topic, and it's not that I disagree with you. I think, anyway, we've got a few virologic failure in the CAB-LA with pivirine LA treatment with 4 virologic failure, all with resistance. So that's also potentially a matter of concern. And, this was not an industry-sponsored study, but that was an academic-led study. And the design was a bit unusual in people fully suppressed because they powered the study for a 10% non-inferiority margin in the trial in people already suppressed. This is what we usually do for naive studies. In people who are already suppressed, what FDA is requiring in terms of study design is usually to have a non-inferiority margin of 4%, because what you expect is that almost all people will remain fully suppressed. And in that study, if you take into account the 4 people who failed in the long-acting arm, whereas none of them failed in the standard of care oral arm, then you cross this 4% non-inferiority margin. So that means, that I'm not sure you can fully claim this is non-inferior. Well, it is according to the way they designed the study, but again, this would have not been acceptable probably if the study was not done in Africa. So I think it still shows that the high proportion of people remain fully suppressed for 2 years, which is quite remarkable, but at the cost of a few virologic failures with resistance. So we have to take this in account.
Absolutely. And I think the good news is that, as we saw in your study, that resuppression after CAB, even with integrase resistance, went well. So I think that's a positive outcome, and a positive outcome that even without baseline resistance testing, the rates of suppression were high. So someone's asked a really interesting question around the lymphocyte count and islatravir and doravirine study. So what they've said is that since the higher dose of islatravir in the previous studies in the past was involved with the lower lymphocyte count, is there any concern that drug-drug interactions that could cause a higher dose of islatravir could lead to this problem? So the good news is that islatravir actually has a very low liability of drug-drug interactions, and it's not metabolized by CYP3A4 or the UGT mechanism. So actually it's a low liability for drug-drug interactions as a victim or a perpetrator. So I think that is a positive point for it. But I think it's an important point that you make, that, in people that have higher doses, that was a concern. So I don't know, Jean-Michel, if you have anything else that you wanted to say about that.
Well, no, I think you're right. I mean, this low dose of islatravir seems to be okay regarding, lymphocyte count and CD4 cell count. It's only 1 year, so I think we need to see, additional follow-up to just be fully reassured. But the question I may want to ask you, Chloe, is what do you think about this combination? What would be its advantage as compared to the other combination we have today for treatment?
Yeah, I mean, I think it's a really interesting point. So, I guess one thing we could, thinking about the future, is that doravirine islatravir would be a great option if you'd been on either lenacapavir or cabotegravir as PrEP. So that would be, a post-PrEP regimen par excellence. So I think that's something that we could say. And it's a regimen where you don't need, for people that don't need an integrase inhibitor. I think one of the most important things about this study is that it paves the way for the future long-acting pipeline. Because one of the most important issues with islatravir is the hope was that it was going to form the base of the future pipeline. And then when the CD4 count signal came, that hope receded. But I think that hope is there again. And that this regimen is the first, it's non-inferior to bictegravir, FTC, and TAF, which is very positive. But it's not quite clear what the discriminator is. I think that's the question you're asking.
Right. Well, I think you're right. I mean, this study paves the way for other combination with islatravir and NNATI. And it's true that another NNATI in development that can be given once weekly, and therefore, this will be reassuring in terms of safety and efficacy for future long-acting oral regimen.
Yeah, absolutely. And then we've got another question for you from your slides, Jean-Michel, asking about some thoughts on the cause of the low concentration of lenacapavir in the case of virological failure on len and bnabs.
Right, that's a good question. I mean, we're not sure that this is the cause of the failure. And, with lenacapavir, we have had so far limited data in people treated with HIV infection because it's usually restricted to people who have multi-drug resistance. So we have more data on the use of lenacapavir for PrEP. And we've seen, for example, in Purpose 2, that although there were very few failures, the 2 failures were also due to, at least for one of them, a low lenacapavir level. So here we've seen a somewhat lower level rather than. Is it the only explanation? We don't know. There was, in that case, resistance to lenacapavir, which was important to point out, so that when you fail with lenacapavir, you're bound to see resistance pretty quickly. So that's a potential limitation. We don't know whether this is the variability, inter-individual variability, or could this be linked to a problem with the subcutaneous injection, because this failure occurred, very early on in the trial at week 12. I think this is unlikely to be linked to the injection site reaction, or because you received an injection into a nodule. So I think this could be just the variability of lenacapavir, in a large population.
Yeah, it's a very interesting question and a very interesting answer. Thank you for that. Really interesting, Jean-Michel. You've certainly helped me to understand that better. There's a question on tecovirimat. Somebody's asked why tecovirimat had a very good efficacy profile in animal models, but this efficacy dose did not translate into humans. And I guess the difficulty there is that, we draw conclusions from, non-human primate studies, and we try and get doses right. But unfortunately, the results did not translate. And that's why there were 2 randomized controlled trials, not just one. And there's actually a third. There's the Platinum study, which is still struggling to enroll, I think, in Europe and the UK. But certainly there are 2 studies which are very well designed, well controlled, double-blinded studies, which have shown unequivocally that there's been no benefit so far in the primary endpoint. So I think sometimes, what we think in non-human primates doesn't translate into humans. I don't know, Jean-Michel, if you have any other thoughts there.
Right, I think you're right. We haven't seen any benefit in this trial, and this is a bit disappointing. The only potential clue was that the viral clearance at week 8 was a little bit better in the tecovirimat arm as compared to the placebo. So maybe there is something here, but this difference in viral clearance was last 2 weeks. The other issue might be either the dose, which was not high enough, or the fact that people were enrolled after a couple of days already of infection. And you may think that for treating this viral infection, you may want to treat people very early on to see a benefit. And, the median time for treatment initiation was a week. So maybe also it's too late. Wait for a week before you start treatment, potentially. The other issue was that the study was done in, non-immunocompromised people, because those were immunocompromised received open-label tecovirimat. And maybe this study could be, been done in people immunosuppressed. Maybe here you may have seen a difference, but these are only, suggestions, because at the end of the day, there is no efficacy, and I'm not sure another study with these drugs is going to be conducted.
Yeah, I think clinicians feel really upset, and there's lots of clinicians have approached me and said, but I was sure it was helping. And I think that's the thing. That's why we need to do randomized studies. It's such an important question.
Thank you, Doctors Orkin and Molina, and many thanks to you, our listeners, for joining in. As a reminder to view the full program, CCO independent conference coverage of CROI 2025, the latest updates in HIV, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.